Okay, I'm sitting here with Seth O'Neill. I think I've been emailing you for like 2, 3 years to try to get you on the podcast, and finally here we are. So, yeah, before we get into it, why don't you tell everyone who you are?
Cool. Well, thanks for having me along, Jake. My name's Seth, obviously. I'm a physiotherapist by background, and geekily did my PhD on Achilles tendon problems, and then really have ended up just staying stuck in that realm ever since. So do a lot of work around tendinopathy, tendon ruptures, and calf muscle injuries. My PhD was looking at which muscle was most involved. We identified Soleus was most involved, and then it ended up spinning out into a lot of the calf injuries because Soleus seems to be the most commonly injured of the muscles in the calf. And sort of our soccer data, it's around 75% Soleus. So I get dragged into lots of talks around calf injuries and tendons. I work full time at the university, so I'm sort of research lead for physiotherapy over here, and then I still do a lot of private work. So I do normal patients in my own clinic, but then I also see a lot of elite sporting individuals across sort of Premiership rugby, Premiership football, at track and field athletics, so GB level, and then also do a bit internationally. So sometimes with basketball players, so NBA guys over in the States as well. So get quite a broad mix of everybody that you might come across with a tendon problem or calf injury. So,
So, why did you get into calves and Achilles?
so probably like most people, when you get an interest, it's either because you've experienced it yourself, or that's all you see day in, day out. And mine was both. I used to work in sports medicine at one of the hospitals in Leicester, and I developed Achilles tendon problems myself, and then used to see it all the time clinically as well. So did my masters around one of the sort of clinical tests we use for Achilles tendon problems. So the painful arc sign, and looked at how it correlated to a MRI scan, and then ended up setting up a PhD around that as well. So it's just one of those things you fall into in life sometimes. Happy coincidence. I like it, luckily, and a bit of a sad geek, so it always works well.
When you had the Achilles tendon issues at that time, what was the state of rehab? Was it good? Did things work out for you?
Yeah, so I mean, back in the days of Elfrichson regime was the sort of the key thing at the time. So using eccentric rehabilitation. So this was early 2000s, and I developed a paratenon disorder from having a tight fitting boot on my foot. So a wetsuit boot, doing some water sports, doing lots of walking in it, and it rubbed and made my paratenon horrendous. And then probably 6 months, a year later, developed a true sort of tendon disorder. So pathology inside the tendon instead. So yeah, self-rehab it as you do these things, and I've experienced it, and can appreciate where patients sit when they've got a problem and how quite disconcerting it can be, which is a big part of it. Yeah.
This paratenon, I or peritendon, whatever they kind of mix the terms. I had a guy a few months ago with I was suspected, and we did some of the techniques, and he got a lot better. But is this something that's this issue? Is it special to the Achilles?
Yeah, I think in every tendon in the body, they've either got a synovial sheath, or they've got a paratenon generally. So you can develop irritation of the sheath around it. So obviously we see them in wrist and hands. You get dequervens, tenosynovitis, so quite a common one, and that's your synovial sheath. The paratenon is just the same. It's not got the synovial membrane. That's all. So it's the same type of effect, and all tendons seem to develop it, but the Achilles is the one that we probably look at it the most. It used to be thought to be like an 80-20 split. So 80% would be true tendon, 20% the sheath. I think nowadays we just sort of say it's normally the tendon, and we've got involvement of the sheath. Occasionally in a younger athlete, so we're talking often sort of teens or early 20s, where they've gone on a training camp and been exposed to a dramatic increase in training loads, they're the sort of person who may just get a true sheath disorder, other than having sort of tight fitting strap in or boots against it. But it's something to squash it and create that friction is what normally happens.
Um, when it comes to the rehab, what are if you have that sheath issue? So you say you can even see it in that kid that goes and does a bunch of activity quickly. So this kind of like muddies the water of like this idea of a reactive tendon, or like, is it a peritoneon thing? Yeah.
Yeah, it does. And I mean, a reactive tendon, we know what the triggers might be. So it basically, if you've got a true tendon disorder, we know one of the risk factors is calf muscle weakness. And obviously then a lot of our rehab would focus on calf muscle strengthening. But for these guys with a peritonean disorder, it's probably not related to calf muscle strength. So we don't really want to focus rehab around this progression of trying to strengthen the person. We probably just need to focus on simply settling it down, taking away whatever the aggravating sort of stimulus was, and then basically just reloading them up. And if they've developed a bit of adhesions between the sheath and the actual tendon itself, which can happen in some cases, then you might want to do something that tries to free up the tendon. So that might be stretchers, it might be isometric contractions, so the tendon slides in the sheath. It might be doing isotonic movements that are full sort of range of motion to free up these adhesions. You can literally hear crepitus in the worst cases. It sounds like Velcro being pulled apart with the worst scenarios that you get of this. So, but yeah, then few and far between, thankfully, and normally sit together with a true pathology inside the tendon.
Okay. Before I get to the Soleus, kind of your PhD stuff, the other one, the peritendon, peritoneon thing.
Yeah.
I think you were one of the first guys on a podcast. This was like many years ago. Talk about the Plantaris or Plantaris, however you say it.
Yeah.
Yeah, can you kind of run down maybe what you've seen over the years? Because I think one of the things you had said was we used to think they weren't seen in a lot of people, they weren't an issue, and then
Yeah.
some newer research, or now this was like 7 years ago or something, so maybe it's not so new, that they exist in a lot of people and they can actually cause issues. So yeah, what's going on with the Plantaris when it comes to the Achilles?
Yeah, it's an interesting issue. So a number of years back, people started to diagnose the Plantaris-induced Achilles tendinopathy, which is basically suggesting that the Plantaris tendon was rubbing against the tendon, rubbing against your Achilles, and creating damage to the Achilles tendon itself. And there's a debate around how many people have them. And I often ask people, well, what do you remember from what you were told when you trained? And it's always a magic 10%. People remember that 10% of people don't have one, or if they trained at a different institute, 10% of people do have one. You've got this discrepancy in 90%, and it's just lecturers remembering things inappropriately. Really, the problem with a lot of the old evidence is when you've got your tendon, they didn't actually cut open the sheath and look inside the Achilles to try and find your Plantaris. They looked around it and couldn't find it, but it's often, I would say normally, embedded inside your peritoneum. In my clinical world, I don't scan many tendons and find the tendon, the Plantaris, sits outside the Achilles. It normally merges with it and is within the sheath. So that's, I think, part of it. And a lot of the research that's been done in the recent years, as you said, within the last 7-10 years, has started to show that Plantaris seems to exist in the vast majority of people. Like any muscle anomaly, you may have a very small number who don't have it, but by and large, most people will have a Plantaris. It's rare for me to scan and not be able to spot it, would be what I'd say. And I scan a lot. We do a lot of research on tendons, and we can normally observe it. And then the debate is how much of the tendinopathy is due to the Plantaris and how we should manage it. Some centres and some papers would suggest that all people with a Plantaris problem have it resected and have it removed. Mine's a little bit more nuanced, and sort of I would normally say that, well, look, the person's always had the Plantaris in that same spot all their life. Why has it become symptomatic now? If it's only been there for 6 months or whatever time frame we're talking about, it's likely to settle just like any other tendinopathy is. And the other challenge is how much of that medial-sided symptoms and medial-sided pathology is actually linked to your Plantaris rubbing, or how much of it is linked to the medial bundle, which is the soleal section, getting more stress and developing tendinopathy. And that's a whole debate. So some centers, some clinicians would suggest they all need, like I said, surgical resection of some description. But you've always got to remember who these people normally see. If that's a fancy clinic, they might be seeing all of the problem cases that have already been through rehab numerous times and have failed, and have then sought this third or fourth opinion. And so they are more likely to need maybe a surgical solution. In my clinical work, normally with normal people, they'll settle perfectly well. In an elite world, that's a different challenge, because then we've got a push to return to performance more quickly. And that's where a lot of elite athletes aren't willing to take sort of 2 to 3 months of rehabilitation and then fail and then need the surgery. So, of course, in the elite sector, what we see is a lot more people will progress to surgery earlier and go through rehab. It is worth noting that I see surgical failures for this approach. It's not a out and out cure for this type of tendinopathy. And I've got some concerns it can be overdiagnosed a little bit. But it depends where you are in the world. I think certain areas have never heard of it. Other areas see it all the time. It just depends.
And so you said this, so it's this medial sided, where you kind of have that suspected pain, medial sided Achilles pain, but you think that can be, so that's also where the soleus subtendon is it goes in medially like that?
Yeah. So if you sort of got your tendon and you're looking at it end on, the ventral surface, the deep surface will be the soleus. But then as you rotate further towards your insertion, the tendon actually twists and turns. And what happens is that the sort of ventral surface will rotate more towards that medial section, which is again the soleal section. So you'll find that actually they may be about the soleus bundle. And a few research groups around the world are actually trying to identify the subtendons within the Achilles of the lateral and medial gastroc and the soleus in their work. And that's, I think, where we might start to see some novel aspects around these subtendons, which are very varied from person to person, and where the pathology is, which in my mind and my practice drives how I would rehabilitate the person. So, for example, if it's the deep surface of the tendon, we can probably assume that might be more soleal bundle, in which case we might want to see how the person responds to doing straight leg versus bent knee loading exercises. You often find it will be a bit more provocative on the bent knee in that instance, because it loads that bundle a little bit more than it would do in the straight leg position, where it will work both bundles. There's some confusion then about what it does to your muscles, and people assume that because it's soleus, we must do bent leg rehab. We don't need to. The soleus muscle itself will work when you're straight legged as well, and it just inhibits gastroc when we go into the bent leg position. So it really depends what we're trying to do here. Is it load the injured site or rehab the muscle? And they both might be targets that we have.
Okay, so we talked before we got on the UTC scans that you do, and I'll say Jared's one of the big guys I know that does it.
Yes.
Those images on the Plantaris, they have that, like the Achilles when you're looking down the barrel, and they have that medial, they have that medial side that is showing that, like the signal, and you can just imagine where the Plantaris is like rubbing on that. But do you think sometimes that can actually just be like that soleus bundle is the one that's being overloaded?
Absolutely. Yeah, that's typically what I observe. And you'll sometimes be able to see on the scan that you've got the Plantaris is visible. You then have a normal bit of tendon tissue next to the Plantaris, and then you have the bundle change. And that's quite common that we may visualize that, in which case I'd be saying it's not about the compression of Plantaris. We've got a normal section of tendon in between. This is a section within that medial pillar.
Okay. Okay. Yeah, you went kind of down the soleus. I say soleus here in the States, but
However you want to say it.
So the consensus, and maybe if you have more to go on that, is if you do a straight leg, you're gonna get gastrocs and soleus. If you do a bent leg, your gastrocs are kind of out of play. Is that accurate? And then what does it do to the subtendons when you do both of those?
Yeah, so it's accurate in terms of the muscle force production, and we know that the tendon fascicles are continuous all the way from the muscle that it's sort of originated from. So what you get when you do the bent leg is you get more of a slide, more movement, more excursion of the subtendons. But again, there'll be some nuance with each individual person. And there does appear to be some crosstalk, but the studies that have used techniques called speckle tracking, where you use ultrasound to track individual fibers of the tendon, show that the deep surface in those instances will move more. So it's a way of loading it more, arguably. But again, there needs to be then an assessment of an individual response. So can you see it if you use imaging, or does it provoke pain or not more than another? Um, the key part here, though, is we're not saying rehab should be done in bent leg only positions. If that's of relevance, we'd still use the straight leg. It's of critical importance to normal function, but we might have some elements of bias, or might often use pronated foot positions, or you might use toe in or toe out positions to again isolate stressors through different fascicles or different muscles.
Yeah. Okay. Bring me back to the PhD on the soleus. So you're when it comes to Achilles tendons, or like, yeah, I guess Achilles tendon rehab, everyone knows about the calf muscles, and then the soleus, the main one that we creates a lot of the muscle bulk. Handles a lot of the loads when people are doing that dynamic things. Yeah, what was the PhD around with the soleus? Was this kind of like a new understanding at the time?
Yeah, so I mean, I started my PhD in 2012, so 2012, and nobody was talking about looking at rehabbing different elements and which muscle was more involved. Typically, at that stage, we had the eccentric regime from Alfredson, which did involve bent leg and straight leg positions, but there was no real concept around why you'd use the different positions. And I'd had a clinical sort of question around which muscle was most involved. When we were looking at our cadavers, so the bodies we use for medical teaching at the university, what you're able to see in the tendon was that often there's still soleus muscle fibers right the way down into the deep section of the insertion nearly. And it was a question then around, is soleus more involved? Because at that time, our studies that we had and the work in the hospital was suggesting it was always the deep surface where we saw the tissue breakdown. I say always. There's always the odd case of the sort of dorsal superficial surface, but the majority were this deep surface when we looked at our tendinopathy cohort. So we had that question around it, and all we set about is just testing where the muscle deficits were. So we essentially used isokinetics. We did a test battery, refined the protocol, published reliability work, and then did testing in straight leg and bent leg positions. 80 degrees of knee flexion to try and inhibit the gastroc. It's never perfect. There'll still be a bit of EMG, but there's very little force production. And basically what we observed was that the strength deficits were pretty identical, not perfectly, but pretty identical, whether you did it in the straight leg or the flex leg, which again suggests it's the muscle that was working in both positions, which is obviously soleus. So that was where sort of the work went, and why we were sort of interested in it. And going back into 2012, nobody understood really what the force propulsion was from the soleus, certainly in the sports and the physio world. Everyone was assuming gastroc is the main propulsor. And we were interested in, well, what does the muscle normally do? How much should our then rehab be? Because back at that time, people were still using TheraBand to rehabilitate the calf after Achilles ruptures or with Achilles tendinopathy. And still now, I sometimes do training courses around the world, and people are still talking about using TheraBand like a yellow one or a red one, and you're talking kilos of force versus the multiples of body weight that we get when you're doing a heel raise. So that was the issue I had, is to make sure when we rehab people, we return the muscle function back to what it was. So that's why I ended up getting on my soapbox, talking about what Soleus does as a force propulsor. Obviously started it off on Twitter back in the day to say, well, look, this is what it should be doing. Why are we doing sort of TheraBand rehab? And then it snowballed from there to sort of help folk understand it. And there's lots of biomechanical papers around the difference in force propulsion from the gastroc and soleus. And I think everybody, hopefully now in sports, has generally got the message that it's massively important. It's not a postural muscle like we maybe got told at university when we did our training. It's a key locomotive muscle, and is inherent to our propulsion and force through the Achilles, therefore should be a big part of our rehab.
The loads, what are the numbers of what the Soleus is, like 6 to 7 times body weight when you're running or
I
something
mean,
like that?
for most steps when you're jogging, you're probably looking at about 7 to 8 times body weight at most speeds. In steady state running, if you then accelerate, the Soleus will get about 10 times body weight for acceleration phases. In the studies that have looked at that, so it's huge. Gastroc, on the other hand, is about 3 times body weight for the steady state running, and then it goes up to about 6 times body weight in the acceleratory phase. So that's like a track athlete coming out of blocks on the track. So it's a case of Soleus, it eclipses all of the lower limb muscles, except when you hit maybe a sprint. But even then, there's a bit of debate around that, because the acceleratory study shows that the Soleus eclipses hams, glutes, quads, everything. It's right up there. So really what we've got to think of is that's our distal strategy. That's what works maximally pretty much every step. But to go fast, we then increase cadence, and that comes from the proximal. And that's why we see proximal muscle injuries when we're sprinting normally. So hammies and quads, maybe hip flexor rarely, but it's that switch. So really it's about what the calf's doing for most of our propulsive tasks. And again, just from an athletic perspective, we know that calf strength directly corresponds to your sprint speed. So whether you're looking at 10-meter sprint distance or time, or 30-meter, calf strength is a direct link to that performance. Now, we don't have studies that have improved people's calf strength to see if you improve your sprint strategy, but there's a strong relationship there, and that would be the suggestion. But we should test that.
I don't know if you're able to answer this. So because I struggled to answer it too. This number that like 7 to 8 times body weight, going through the Soleus, and then I think I had some argument on Twitter with one guy recently, but I think he was talking about the TheraBand type training,
Yeah.
training calves lighter, and then I'm like, well, the Soleus deals with this amount of loads, and then they say, well, are you saying I need to hit that then in the weight room? I need to do a single leg calf raise with 7 to 8 times body weight, and I'm like, no. How do you explain this difference if we talk about, okay, the Soleus is dealing with this amount of loads instantaneously versus like when we're in the weight room?
Mm-hmm.
Is it more like the TheraBand stuff is too light and we need to just progress closer to these type of this idea of how much loads it's progressing? That's why you need to train heavy, or how do you look at this? Yeah.
So it's a quite simple explanation for it. We're talking two different elements. So when we're talking about the sort of internal load, we've got to understand it's internal loads. So that 8 times, 10 times body weight is an internal force production. And that depends on the lever arm and the axis of movement. So if we are looking at measuring that externally, so we use an isometric strength test in a flex knee position. You've got your foot on the floor. The axis is through your metatarsal heads. And then you've obviously got your calcaneum at the back and your Achilles coming down. So you can work out a typical sort of lever arm for that. If you hit twice body weight as an external force production on that test, the internal force will be between 7 and 12 times body weight, depending how big your foot is, basically. So that equates to the typical internal physiological load. So externally, twice body weight is our target. Internally, that will be then somewhere in the region of our typical demands. And we've got a large amount of data to substantiate that. So we've got a large rugby orientated study, 350 players, backs who are the guys that are like your runners you have in NFL. They're the equivalent of the guys that are doing all the running around and on the wings. They'll hit twice body weight is their average force. If we look at a whole load of players, a whole squad. If we look at the forwards, they're the ones doing all the heavy hitting. And in a scrum, in a rugby perspective, they'll be lower. They'll be about 1.8, 1.85 times body weight. Interestingly, they're the ones that get most calf and most Achilles injuries, though. And they still have to move their body weight around on field. So they should be stronger to cope with the internal demands, but they're not. And we've done the same data set in 150 professional football players, so soccer players, and they're 1.95 times body weight measured in a normal training week. So we're happy that that's an arbitrary target that we should be able to achieve for people who do running-based sports on field or on track. I would argue that we should be stronger, particularly in elite sprinters. But that's our arbitrary target. And like we said, the internal force then will be in the realm of 8, 7, up to 12 times body weight, depending on their lever calculations, which will vary. So
Mm.
it's that. Or really, if you're talking to somebody in the gym, you want to lift, they should be lifting 1.5 times body weight as a minimum in order to actually be hitting a threshold that's around 80% of their maximal voluntary contraction. That's the key here. So that would be my body weight, me standing, and then additional half body weight in a Smith machine or on a squat rack or whatever we're talking about. It gets different when you look at leg pressers or seated calf work because the lever arms are different. So you might only be lifting 100 kg or whatever that is in pounds, 225 pounds, 250 pounds. But it's a case of the lever arm calculation will make it harder maybe on the tendon and the actual calf work. So you have to do a bit of thinking around it.
Is this, so you have this in a paper?
Yeah, I mean,
This
I've
is kind of
got
explaining.
presentations that we sort of try and use as a calculation. I mean, a good one for this is Rich Willie. He's over in the States. Rich has done some work around that, and we have a nice little graphic we use on a lot of our paper discussions around that. But we have mentioned it in the papers. So in the paper by Matt Lee, it talks about the internal loads in there and how that relates to that external measure. And it's in our footy paper. I can't do a screen share, can I? Can I do a screen share? Let me see if
I think you could send, if you could send it to me, I could put it in the show notes.
Yeah.
Because I think I've been trying to, as you started explaining, so there's this, the guys at Inform Performance. I don't know if you were on their podcast, were you, Andy McDonald? And then so they had a calf profiling resource that was like super cheap and really high quality, and they had a part in there where they're talking about something you had said or one of your papers where you were kind of explaining what you said here, but I think what they were getting at was the strain experienced on the tendon. And I think I reached out to it was Andy McDonald and Dylan Carmody. I reached out and I was like, where is this paper? And they were looked, but I think they had a hard time finding it. So my question is this idea of like, if the internal loads are the same, with the running and then that heavy calf raise, what is the strain on the Achilles tendon? Is it going to be similar, or is it way less even with this 2 times body weight seated
Yeah. So
isometric?
the strain is a different metric as well. So we've got to be careful when we talk about the loads versus the strains, in terms of the actual what that means on the material of the tendon itself. So that length change is different from the load through it. And the strain is often talked about as 7 to 8% will be the typical strains we want to hit to get physiological adaptation. But that's also the level where you'll start to get rupture, 8% elongation. So what we're trying to do and what some people are looking at now are whether we can individualize rehabilitation actually using measured strain in the tendon. So we load people up in the gym using whatever exercise. We measure the elongation on the relevant section of the tendon, and then we use an appropriate force to generate that strain to rehab. So that's the key part, I think, there. And that's where we get confused, is when we talk about what we might use as colloquial terms for strain versus actually a biomechanical term for strain. And that's sometimes the loss in translation between talking with research groups, talking with clinicians, talking with an athlete. We use the terms sometimes interchangeably. So it's just to be very clear what we're about.
Yeah.
So I tend to try and use load and use body weight force because it's easy for people to interpret rather than tendon elongation, which we can't measure unless you're in the lab. So I avoid strain normally for that reason. Yeah.
Yeah. I use it because it helps me understand like what the tendons getting longer. You lift a heavier load, you're probably getting more. But yeah, exactly. I don't have an ultrasound probe on to see what's happening.
And it's like I said, it's hard to interpret. We can make some assumptions with how much is elongating it, but we might be wrong. Is basically what some of the guys are starting to identify now, and it is really individual, with depending on your makeup of your tendon, how much rotation you've got, and which muscles are generating that force. So it's something I think we'll probably watch this space. I think you're going to start to see some rehab interventions designed around that in the future.
Yeah. Yeah, I had one of the Berlin group guys, Falk Mersman, on
Yeah.
maybe 1 year ago.
Okay.
Yeah,
Cool.
to talk about the strain and then the
Yeah.
individualizing and really honest, because I have a lot of not criticisms but just questions around it. And yeah, very individual it seems like. Even I think Carr and Silvernagel did a Spanish squat study,
Yeah.
and the strains were like from like 6% to like 12%
Yeah.
in a variety of people. I was gonna so on this seated calf plantar flexion or any calf training, I think still to this day, people there's like this obsession with hitting full plantar flexion or training in plantar flexion. How much less of a training effect are you getting there? How much weaker are the calves in that
Yeah.
plantar flexion range?
So the biggest fault I come across with tendon rehab and calf muscle rehab is a overly focused on the plantar grade up to plantar flexion. You're talking about half the force capacity of a dorsiflex calf position. Injuries occur in an eccentric phase into dorsiflexion. They do not occur from plantar grade up to plantar flex positions. Even when we look at triple extension in sport, it's a recoil. It is not a force generation position. So my real bugbear, I guess, when it comes to rehab is that we spend all this time from floor, plantar grade, up to plantar flexion. We focus on developing inner range strength. Inner range has no relevance to sporting performance unless you're a gymnast or ballet dancer. It's not relevant for field-based sports. We need to develop huge forces in dorsiflex positions. You look at all the Achilles ruptures in the NBA in the last last year. If we look at the 7 that occurred then and you look at the slow-mo footage of them, they are all about a dorsiflex in position with the knee extending, with the hip in extension. That's the position we should be training our athletes in to make sure they're robust in positions of relevance. All of our calf injury videos that we've looked at are all the same mechanism. And our Achilles tendinopathy, that's the biggest Achilles stress. That's where the degradation occurs. That's the position we should focus on. And like we said, it's about 50% more. So, for example, if you can hit 1 times body weight when you're in a neutral position, you're probably getting 1.5 times body weight in a full dorsiflex position. We've just done a nice paper on this with 500 healthy people using the bent knee isometric test. We've got it under review at the moment. And basically in that paper, you're getting, depending on what cohort we look at, so in a 20-year-old person, they'll hit 1.8 times body weight. So these aren't field-based athletes. They'll hit 1.8 times body weight in dorsiflexion. They'll hit about 1.6 or thereabouts in a plantar grade position. If we put them in plantar flexion, which we haven't done as the study, but when we have tested it, they're probably in the region of 1.4 or 1.2 times body weight. It is a big difference between plantar flexion and neutral or dorsiflexion. And it's our rehab needs to focus on neutral, plantar grade, down to dorsiflex, full dorsiflexion ideally.
Yeah.
I can't stress it enough. It's the clubs I go into and work with, and they've been doing rehab and they're sort of banging their head against a brick wall. It's always this same story, and it's because of some of the isometric push that people have been putting out, both in America and in Australia, around isometrics and rehab, and they're all focusing on this up position because it's easy for us clinically to visualize a deficit because people are weak there, they can't hit the top, and we go, oh, they need to hit the top. They don't need to hit the top. It's a way of proving they're weak if you don't have all the strength kit to test them. But we need to then go to the positions that are functionally and performance linked, which are the dorsiflex positions.
Yeah. Okay. A lot of questions. Let me
Sorry,
ask this one first. Okay, so when someone gets and maybe this throws all that out the window because it's a different case, but like the post-rupture people, they always struggle getting that plantar flexion range back. So is that a case where like there is a lot of use with those people that can't hit that range, or what are your thoughts there?
Yeah, I'm not bothered by it. So literally my counsel when I'm doing a consult in pro sport will be that this is largely irrelevant unless we're ballet or gymnastics, in which case we need to focus on the other positions. We'll test them using isokinetics to show them their deficits through range. And when we look at the deficits with injured personnel, whether it's a rupture, a calf injury, or tendinopathy, the deficits primarily exist in neutral to dorsiflexion. And again, this is where the proof's in the pudding. And we've tested this. We've got all the data. It's in the papers. That's the position we need to work at. And you'll see that basically as they're going into predominantly an eccentric phase is where the deficits are really easy to see. But they'll get a trough. So instead of a straight line of force generation, they'll get this trough where they don't generate force properly. And so if you imagine that occurs in a step back, the person's stepping backwards, they can't generate eccentric force in this step back. Then all of the contractile tissue can't shock absorb. The inert tissue, the tendon, takes the brunt of the force. And this is why you see tendon ruptures, tendinopathy, or you see an intramuscular tendon injury. So if we look at Soleus injuries, they're predominantly around the intramuscular tendons, or sometimes termed aponeuroses. And that's it. That's the mechanism by which it happens. That the contractile tissue should have shock absorbed. It hasn't done. The brunt goes onto the other tissue. So in answer to the question, I don't fret it. I'll say, well, look, it's a way of proving you're weak. Let's test you to find out where your weaknesses are using isokinetics. And our rehab needs to focus on this because this is our performance bit relevant on field. How often do you go into a true triple extension position versus how often are you stood, ready to receive the ball in whatever sport with your knees flexed, your foot dorsiflexed, and actually that's the position where you're predominantly working and we need you to be functioning better.
Mm. Okay. Yeah. Yeah, still okay. Oh, that's good. All
So
right. Yeah,
I know other experts would talk to you about, and they'll use that position. It's just not relevant. The only time I will use plantar flexed loading is post rupture in the early phase. So maybe 3 weeks, 4 weeks from rupture, you've had a surgical repair. We'll take the boot off. We'll keep you in a wedge. We'll undo the straps and we'll get you to do an isometric contraction in those positions for early loading that's not at risk of actually elongating or snapping your tendon. That's the only time that position's ever used for me for loading.
why do you think that this like restoration of full plantar flexion, why did that even become a thing? If you're so what you just said with like, yeah, all of the importance with the Achilles and the calves is going to happen neutral to dorsiflexion. That's really when things are happening there. And then we have this obsession with we need to full plantar flexion. Why did that come about?
I think it's because when people don't have kit to do testing, they can clearly see the deficit in that position. So if you don't have a force platform and you don't have isokinetics, you can get somebody to do a heel raise and you can clearly see they can't hit the toe. So there's a clear deficit. And then Karen, as you mentioned, Karen's works around heel raise performance and endurance post-rupture. And it's clearly identified this deficit and it's easy to spot in that plantar flex position. So like we said, I think people have confused the ease of spotting a muscle weakness with where we should work for performance. That's not the case. And it's a misconception, as often happens in the physio world and physical therapy world. We saw it with eccentric rehab. We saw it with isometric rehab. It's being confused as a panacea for all these conditions and stuff, and it's not. And people misunderstand what the evidence tells us. There's an old paper years ago on Achilles tendinopathy, and they showed it compared eccentric rehab versus concentric rehab. And people said concentrics are bad. They weren't bad. They weren't harmful. They just weren't as good as the eccentrics. But the dose was very different. They didn't use body weight until later in the rehab. And it was just a dosing issue. But people assumed it was bad. And I think that's the case here. People assume we want to work in this position because we've shown deficits. But it's just a way of spotting the deficits. So Cameron's work does total work that you do through the rep, your total height you've lifted, as well as then your peak height. And the peak height will be reduced. You'll probably never get it back. You're chasing something that is a real struggle. I say you probably never get it back. if you've got a ballet dancer, you must get it back. It's critical. Okay. So work with British ballet, sort of, yes, you've got to get this, the Royal Ballet over here, basically. You've got to target that. And that's a very different subspecialist group. So always be aware of the population that clinician, that expert works with, that talks to you about these things, because often it might be more dance orientated and not field sports orientated. And that's sometimes, I think, the difference with it. So we do use calf raise measures. We do use peak height that they've achieved as part of a metric for research. But as I say, clinically, I'm not chasing that. I'm chasing the force in this lower part. So yeah.
Mm. Yeah, I came across a paper recently, and they just had a photo of an Achilles in like full plantar flexion, and their term underneath was it's kinking. The tendon was kinking in full plantar flexion. So I was like, people, how can you possibly think you're getting good Achilles load in a position where the tendon would be like
Yeah.
almost like bent up, you know?
Yeah. I mean,
Yeah.
let's talk about biceps. We want to do some bicep work in the gym. Do we want to work up here? That's what we're describing for the calf. You're working it in the equivalent of this in a range position. You wouldn't do it. So
Yeah. Yeah.
let's flick it around that way.
So when it comes to calf training, Achilles, actually, I guess before I get to that, so you said neutral, and then as you get deeper dorsiflexion, the calves get much stronger. How do you deal with that information? And then also, if someone has an insertional Achilles pain and maybe they're sensitive to deep dorsiflexion, how do you balance the two?
Okay. So we'll deal with the first bit first. So the deficits also depend on what contraction mode we're looking at, whether it's a concentric only, an eccentric only, or whether you're doing a concentric eccentric task, the heel raise. Concentric eccentric will bring in energy storage in the tendon, and actually you get a lot more recoil. And obviously we know when we look at any muscle, the eccentric force you can generate is often double what you can get concentrically. So what that means for rehab is if we do a concentric phase, we'd probably use both legs and get you to lift the weight that's really hard to lift on both legs. And then you can probably lower the weight down on one leg. Now that's the way of actually getting the dosage for the eccentric phase correct. Because if you're using what you can concentrically lift and then eccentrically lower, it's too easy. You're working well below your sort of MBC of 70 or 80, which is, we probably want to be high up there for tendon adaptation and neuromuscular adaptation. So that's part of it. But as you identify then for insertional tendinopathy, we may have some issues with dorsiflex positions. And again, this is a misunderstanding of the research, I think, although there's some papers we probably need to flag. So the reason I say it's misunderstanding is people have perceived that the devil, the thing we should avoid is dorsiflexion when we've got an insertional tendinopathy. And people say it's harmful. Look, we're dealing with people who run. So field-based sports, court-based sports, whatever we're talking about, walking even, you go into dorsiflex positions. We have to rehabilitate the person to cope with dorsiflex positions where they'll get both a compressive load against the calcaneum from the tendon being squashed, but also the tensile load at the same time. It's critical we rehab the person to cope with those two elements, tensile and compressive load. It might be in the irritable phase where the person is flared up easily. We isolate those loads and then work towards it. And when you're looking at research studies that have then looked at doing dorsiflex positions versus just to plantar, they show that it's better for the plantar. I get that, but you have to look at who they included. If this is a short-term tendinopathy that's been there for less than 3 months and is in an acute flare, then they're irritable often. And of course, what you're doing is you're modifying the rehab to their irritability level. But in the longer phase ones where they're still running, they're still performing on court, we have to integrate those loads back. So I think we have to be careful with what the research says and who's in the study versus who we're talking about when we're managing people. And that needs, again, a bit more thought around it. So don't avoid dorsiflexion. It's normal. Patients have unfortunately heard us speak, heard podcasts around it, read papers or read blogs, and they think dorsiflexion is bad. They're wedge. They wear a wedge in their shoe. They wear high sort of heel drop shoes and permanently try and avoid dorsiflexion. And that's where we actually need to swap their rehab. So it has a definite use, but in a non-irritable phase of rehabilitation or non-irritable person.
Okay, yeah. How do
I think
you
that's both.
how do you so I've seen this a few times with those insertional, like pretty that can be aggravating with deeper dorsiflexion. It seems more aggravating. Oh, maybe this is an individual thing, but I feel like I've seen it enough times where it seems to be kind of a trend. Standing deep dorsiflexion seems less well tolerated than a seating deep dorsiflexion. Um, or am I just like having too few of cases, or do you see that yourself?
Uh, I mean, absolutely, possibly. It's probably just about load. Doing the standing versus a seated one, you're probably just getting more load on it. If you've got the body weight for starters, I'm 100 kilos. So what's that? 230 pounds. How do I replicate that in a seated position? I can't put a barbell on my leg that's that weight. And I'm always a bit facetious and say, well, you're probably loading with equivalent of 70 pounds, 80 pounds on the leg, and you're doing it in a barbell on that position and doing these lifts. It's not the same force. When I teach a course, I normally find the biggest person in the room and get them to sit on my knee and give them a hug and then lift them, because you can lift a lot heavier weight than you perceive. And I think that's the problem. That might be why you see there's a difference between the bent leg and the straight leg. My challenge to you would be to stand the person and do the same exercise and bend their leg and do it with the leg straight and see what you find then. Now, you might find it is sorer because you're putting sort of more strain, as we talked about, through that deep surface by bending the leg. So that might be what happens there. But yeah, it depends. So I don't fret it too much. But
Yeah, yeah.
I would always find what is the position that hurts the most. And what I'm trying to do in rehab is clear the pain in that movement. So much like you've got a person with back pain, you want to make flexion pain free because that's what hurts them. With this, we want to make that heel raise in the straight leg position pain free. If I can do that, we've rehabbed the person and they'd return to hopefully some resemblance of normality. So that's where we sort of would focus clearing the pain. And that's the other bit that gets missed in rehab. People don't try and clear the pain. They avoid doing that because it's making them worse. Whereas I'd go, well, let's do a lower dose. We use that to make you better.
Hmm. Yeah,
Yeah.
exposure therapy. Yeah.
Is it exactly that? Part of it's that if they're psychologically worried about it and avoiding it, so a normal person, then absolutely we need to do that. If it's an elite athlete, they've still got a psychological fear. So you could use Tampa Scale of Kinesthesiophobia, the TSK, to look at that. But a good clinician will pick it up as well. But I'd still use it to sort of quantify it, and then use it to improve them. But equally, some elites will not be fearful. It just hurts them. And we don't necessarily need to expose them to much. And it's not so much exposure therapy, it's then actually physiological load. It's adding compression and tensile load in order to trigger a more positive adaptation. But as with all tendons, it has to be activity modification. I normally talk about Goldilocks and the three bears. So it's getting the Goldilocks zone where the porridge was just right, not too hot, not too cold. For this case, it's not too much load, not too much compression. It's just the right amount in order to get the person better. And it's trial and error. You can only test it and see how they respond.
Mhm. Okay, so with this, your ideas around insertional, people will bucket the say mid portion insertional need like a different approach. How do you look at this?
Yeah, they all need the same approach, is how I look at it. I mean, some of our data has been very novel that we've identified about 20% of people will have both. So insertional and mid portion at the same time. That's something that you won't read in the literature and you won't find in the papers, but is clinically what we observe when we look at large numbers of people. So how do you then do that? So I think you can rehab a mid portion without going into dorsiflex positions if it's a normal person. By normal person, I mean sort of literally like a work colleague down the corridor that's not particularly sporty. as soon as you talk about elite sporting individuals, the rehab's very different, and we've got to ensure all positions become pain-free and need to become the later phase of rehabilitation. So I would always then utilize it in that later part.
So when it comes to that, yeah, I guess for either any of those Achilles pains, what does your rehab look like? Are you doing straight leg calf raises, bent leg calf raises,
Yeah,
or what? Yeah.
yeah. I mean, the focus for us is to try and get the neuromuscular function better, um, and the tendon to adapt. So that's really what I'm trying to do from a rehab perspective. Actually, there's three things. There's the psychological bit as well. So fear avoidant beliefs, catastrophizing, all of these other aspects are critical. Get tendon structure and get neuromuscular function back. Neuromuscular function is my key. And I say that because we think it's the chicken that lays the egg. There's a study that's published already on army recruits, small number that developed symptoms, but they showed strength deficits prior to symptom development. Okay, so it suggests that chicken and the egg. We've done a very large study then in elite rugby over here in the UK, 350 plus players, looked at calf strength using the isometric test over a season at 3 time points, and identified the weaker players are more at risk of calf and Achilles problems. So that data is under review at the moment. That's a big study that's robustly done with decent stats. So we think that's the critical bit we want to change. And then when you look at strength properly, it's not just the force they can generate, it's actually a neuromuscular issue. So what we see in the lab when we were doing my PhD data is a tremor. So we see during an eccentric phase, you get this shake of the muscle. And most of you, if you do a slow eccentric lower, you'll see this on your patient cohort, particularly if you go into the dorsiflex positions. And often more commonly, when you put the person into a bent leg position, you'll see the shake. Now, that basically has been termed all sorts of complex things, but it's what it comes down to is it's a fast twitch motor fiber not coordinating properly during the eccentric phase. That's basically all it is. It happens at 8 to 12 vibrations, hertz per second, and it's a fast twitch fiber. So we're trying to rehab to improve the fast twitch coordination. That's what we're after, and you can do that using slow eccentrics. Bizarrely, the motor pattern you use for an eccentric contraction, whether you do it slow or fast, is the same motor pattern. So it will transfer over to fast work. And people have shown this with studies on heavy eccentrics done slowly, improving stretch shorten cycles dramatically. So it's definitely the way to go. So we'll look at the neuromuscular aspect to get that rehabbed. And then, of course, what we're trying to do is adapt the tendon. Now, there's two bits about adapting the tendon. It can definitely adapt. The donut and the hole theory is not what we see. We've just got presented last week at a tendon conference, at Denmark at Sports Congress, work showing even the ruptures with gross fibrosis adapt over a period of time. So this is really fibrosed tissue that really does adapt. Both the cross-section gets smaller over a long period of time, and the diseased area, disorganized tissue, those red bits on the UTC scanner, getting smaller. So this is what's happening when you do tendon rehab. And that happens for two things. It happens by loading the tendon, the stimulus for the tendon cells, which is part of what we do. But it also happens because we've got the muscle to function better, and it's now controlling the force through the tendon better, and that allows it to recover. That's our working hypothesis, and we've published a paper around that in the past. So again, we need to test that theory and make sure that it does stand up, but that's how we think about it. So neuromuscular tendon adaptation and all the psyche stuff often comes by doing the two other things, because you're proving to the person it's robust, it can cope, and it doesn't make them worse by doing the tasks. That actually works really well to reduce a lot of that fear and those thought processes when you do that well. So sometimes we'll need to hit it specifically, and we need to show them the tendon's strong. We need to show them that their muscle is functioning well and they can cope with these forces and demands. But that's ultimately my sort of typical rehab. Whether that's then in dorsiflex positions or not, depends on who we've got and how irritable they are. But to do that, we'll use both bent leg and straight leg, which was your original question. But we make sure that we look at, if it's a medial bundle, we'll pronate the foot more commonly. We test them to see if it hurts when they pronate. If it does, that's the thing we need to clear. If it's the lateral bundle, we'll often look at a supinated foot or a varus knee. And again, we can use those positions to then load them specifically. What I really hate is a pristine gym-based rehabilitation program that doesn't use, often I've termed it dirty, on-field positions. So these players, when they're out on court or in sport, they will go into very extreme positions of rotation of the foot and the tibia and the hip that will load different fascicles in the tendon or different muscle bundles. And that's how our rehab should be. The players often, or athletes, know something hurts them, they avoid it. And this is what causes us the problem with return to play, that they've been avoiding this position for a long period of time, not telling the clinicians that are dealing with them. And you'll spot it when you check all these positions, find one that hurts, make that better, they'll perform a lot better than out on field because they're not subconsciously avoiding it. And you're not doing it then when they can't focus on how they move and flaring up after the game, which is typically how it goes.
So this neuromuscular function you kind of talked about with that tendon tremor, and I've tried to Google this, and you're the only video that comes up on this tendon tremor of that
Share with
the
you the papers. So there's three of the papers. So there's Jonathan Rees, Henriksen, one of those sort of Scandinavian groups, and then Grigg over in the Australia has done work on this and identified it in the tendinopathic group. But they called it all sorts of weird stuff. That's why you can't find it. They called it tendon oscillations, force frequency vibrations, and God knows what else. And it took me about 6 months to figure out what the hell they're on about. So yeah,
okay.
so that's why I'll share the paper with you. I have a slide on my teaching that sort of covers that, but it's been found by other people before I sort of talked about it. It's just that I didn't know what we were finding, and they talk about it as the tendon, whereas I talk about the muscle, and that's what we're trying to change.
Yeah. Yeah, okay, because this neuromuscular function you talked about, like controlling the muscle, but then if there's like poor neuromuscular function, the load will go through the inert structures like the tendon, because there's not much neuromuscular control with the tendon like there is with the muscle. So are you looking at, yeah, if you don't have this good neuromuscular function, like you're just going to end up stressing the tendon more?
Yeah. Basically, my current thinking is if you've got poor neuromuscular function, we don't know how we really define that. We often use force as the measure at the moment, the strength. But if you've got poor neuromuscular function, we think you're more at risk of developing a plantar flexor injury. And that could be tendon rupture, could be tendinopathy, could be a calf muscle injury, all of those things. There's a fourth one, which is ACL injuries we'd add to it as well. So your Soleus particularly will pull your tibia posteriorly, about 30% of your capacity of your hamstrings. And we've got some work underway with Rich Norris in Liverpool that's looking at post ACL repairs and what happens to your calf. But basically in the work we've already got, we've shown big deficits in the calf function post knee surgery, post knee injury that does not resolve when people return to play. So we've got elite rugby players been rehabbed for a meniscal injury or ACL repair, or even footballers. And then you find that they start to get Achilles and calf stuff. You measure the calf, it's way down. And that's been part of it. And we've identified this in guys prior to the onset of the calf and Achilles now as well. So they're the big bits we want to look at.
Okay. Achilles rupture. Why did they rupture?
Okay. $1 million question. NBA, interesting, isn't it? So 7 big ruptures last year, 3 in the playoffs. I don't think people are looking at it in the right way, if I'm honest, at the moment. So I think you need a perfect storm. And currently where I put my money at the moment, and again, this is where you need to test it. And we've sort of suggested we should test this, but it's not been funded at the moment. Neuromuscular function, important. These people have done a step back. Normally, when you look at all the rupture mechanisms, there's nothing fancy about that step back. They've done it 100 times, maybe in that same game, but not done it. So something misfires at that point, a bit like an ACL injury where you get the quads and hams misfiring and you end up with the anterior translation. So part of it's a misfire, and that's probably down to then poor neuromuscular coordination in the first place, fatigue, all those other bits that are part of it. You probably need the tendon structure to be abnormal. So And I say probable because we've got data that suggests maybe not. There's a lovely study that's been done. Again, I can share the reference with you, that looked at biopsies post-rupture. Years ago, the work all suggested that people had gross pathology prior to the rupture occurring, much more significant than tendinopathy normally is. There's a new study from, I think it's Korea, could be China, and they basically found about 80%, it's a bit less than 80%, of people had gross pathology prior to a rupture when they'd taken a biopsy at the point of a surgical repair. But that means 20% didn't have that. And that then gets interesting. And we've got 16 ruptures. We've actually had UTC scans within a few weeks of the rupture happening. And what we found is 14 of them were predictable based on the imaging. So the really gross deterioration in tendon structure. 2 weren't. 2 of them had absolutely pristine tendons. And we went back and checked these after the ruptures had happened, obviously. And that makes it interesting then. But what we've retrospectively identified is that the tendon cross-sectional area, the amount of healthy tissue, is super small, below the normal levels, especially when you then add in that these are very explosive. They're both athletes, both very explosive athletes. So huge force generators for the sports they were doing and their weight. That makes it a bit more interesting then. So it's maybe possible, if we stuck with the NBA as the example, that those injuries occurred in perfectly pristine tendons that were very small cross-sectional areas. But having said that, they were all in a simple step back, a normal task, and I suspect they were all grossly degenerative before. But that's my suspicion. I don't have data, I don't work with those squads and stuff, but that's where I think it sits. So if we're trying to prevent ruptures, for me, you've got to look at all of those elements of tendon structure, muscle, neuromuscular performance and strength, and trying to spot the perfect storm happening. The athletes travel, they're absolutely knackered, not feeling very well. They may be more likely to misfire. Sorry, the third bit I forgot to say was also then tissue stiffness. So we look at using something like elastography to measure tissue stiffness. So when you get tendinopathy, the Achilles becomes less stiff, which means it will elongate more for a given load. The strain is bigger for a given load on the muscle and tendon. And that's what happens in the worst tendinopathies. They'll start to become more compliant. So it elongate too much, and then you've suddenly started to break the bonds and your rupture happens. That's what I think goes on with them. They get all 3 with the misfire bit. But testing that and proving it's a whole different ballgame, isn't it? Because you need hundreds of ruptures, or at least dozens of ruptures. How ethical does it get to follow those people, study them without doing an intervention if you think it's at risk? And you need funding to cover multiple years to expose people to that type of sport. So that's the challenge we've got. So the best guess, that's where I go, but I'm probably never going to get to prove it.
Oh, okay. So that elastography, looking at tissue stiffness, if they're less stiff, elastography, is it due to something material in there, like more fluid, or what do you?
Breakdown in collagen tissue. So basically, if you've got your collagen type 1 bundle, so on a UTC scan, the green and blue, you're good. If you've got the smaller strands, that's where we've got collagen type 3 and immature collagen 1 bundles. They're not as stiff, they're not as robust. And that's what we see in tendinopathy. And that's really what we'd expect to be going on here, is that area has become more compliant. So that area elongates more. Now, once that area started to rupture, so during that step back, then all of the stress then goes on to the healthy tissue that's still there, because there will be some healthy tissue. And then you end up with your full rupture. And if you ever get to go in and look at a rupture being repaired, they're not this transverse rupture that we have in our heads. They're more like a spiral fracture. The tendon's gone in different sections, or actually a better example would be a frayed rope. We've got our bit of rope, we've got areas that are frayed, and we've got intact, perfectly normal rope as well. That's what we get with a tendon. And then all the force goes on the healthy bit, and then it goes twang, which is part of my wonder about the study on pathology of where did they sample, and how do you choose where you sample from? Could they have sampled from the healthy rope, but actually there's gross pathology around that healthy section? So that's part of the debate with that. But like I said, we've had that happen to us as well.
These guys with the small cross-sectional area, um, genetic or what? What do you think?
Yeah, possibly. So there's a nice big study in the armed forces in the States that has shown that people of Black heritage, Afro-Caribbean heritage, were more likely to suffer Achilles, patella, and quads ruptures. And we don't know why. But that's really where I'm sort of going at the moment, is there's maybe a genetic difference in cross-section area in some cohorts, but this is probably again individual, and it's probably not about necessarily a race per se. It's just individual, and some genetic elements on collagen genes. So again, there's collagen 5.1a, so collagen 5 gene, that links with the ACL injuries. It links to Achilles ruptures and Achilles tendinopathy. But all of the studies have unfortunately just been white Caucasian cohorts. They're not on mixed sort of heritage groups or on people of Black or Asian heritage. And that's partly what you have to do with genetic studies, is control everything. And that's why it's been done. But we need that to be done across larger cohorts. But that's definitely a factor, and it's understanding why. So something genetic, but who knows what.
Yeah. Okay, you I think in the past, and now recently too, there's the antibiotic fluoroquinolones that people are scared about in the causing Achilles, or I guess
Yeah.
any tendons, but Achilles ruptures, Achilles tendinopathy, based on some research. But I know you were kind of critical of this even years ago, and then recently at I think at Sports Congress there was
Yeah.
a guy who had a talk. I asked him on Twitter what it
Okay.
was, and he said that there wasn't a whole higher risk compared to another antibiotic. Anyways,
Yeah.
yeah, tell me your thoughts on
Okay.
fluoroquinolones.
We know this study is going to be controversial. Okay. This is going to create some issues. And we need to make sure we've got a belt and braces assessment of this prior to the full publication. But we are confident that this is accurate. So the background to this is, like, our local hospital down the road did a drugs audit. They do, all hospitals do this regularly. They did a drugs audit and asked them to send it through. We were interested in setting up a study around fluoroquinolones, so ciprofloxacin being the typical drug that's used. And they'd done 5,000 prescriptions in a given week on fluoroquinolones. And then you go, oh, come on, then we're surely going to see loads of ruptures or tendinopathy. Nothing. So there's no consequence of that level of prescription in an area that has one ER. So all of those ruptures would have come through if they were going to rupture, which starts to then beg the question. And then Matt Kenyon, who's the guy who's led the work, has got access to a system called Trinetics, which is a large medical database of 300 plus million people. And what we've done is built within it, it's got software around research and how to build groups of individuals. So we looked at all those that ruptured. We then looked at the group that had ruptured and tried to then split it for were they given fluoroquinolones or not. And basically, there's no difference in the group. And then part of the discussion was, okay, well, maybe inflammation's part of this. We should look at whether actually we match it with another antibiotic. So we picked another antibiotic, amoxicillin, to go, well, then they've all got systemic inflammation from the infection that they're giving the antibiotic for. So Matt's built 2 cohorts. I think we're at 4.5 million people in the group that were given fluoroquinolone and 4.5 million people that were given the amoxicillin. And then you can look at following the people up from when they prescribed the drug for 30 days, or we've done 3 years, just as arbitrary time points, because most ruptures occur within 9 to 10 days, according to the literature. And there's no difference in the cohorts with the amount that ruptured. They're actually less than is the normal population. So normal population will be about 8 per 100,000, and it's a bit less than that. So it begs the question of, is it really a risk? And then what we've done to be 100% is then we've looked at different groups. So we looked at a group that were older and given Levo, which is one of the ones that's been associated as a bit more risk than some of the other fluoroquinolone drugs. And if you were over 60 and given that, you had a marginal increase, but even at that point, you were still below the frequency of ruptures we'd typically expect in a normal population. But it was marginally more than the amoxicillin. So maybe there's a risk in one group clinically if we go there and forget the research. I mean, that this study is massive. Yeah, it's millions of people. And it's a bit like doing a longitudinal study. You're never going to get to follow millions of people up for years, but this allows us to do it based on the database. There could be problems and people could be miscoded. But clinically, how I look at this is if you've got a really degenerative tendon and you're given the levo, the high risk one, and you're older and your tendon is really poor structurally, then there might be a risk there. But if your tendon's healthy and you're given this drug, you're probably not going to get a problem. That's really what it probably suggests. But we need to be clear. We're going to go for a big journal with this. And obviously the FDA over in the States have a warning on this drug. Our sort of drugs background is the same as well. Europe carries the same. So it's being sure here. But all of the studies that are currently published are association study. There's none that are this longitudinal design format. And that's the key here. They all go, well, I look at everybody that's ruptured. Oh, and X number were given fluoride, therefore it must increase the risk. And we see this, but how many people were prescribed the fluoride first and then went on to rupture? That's really small. And that's what we've done. We've looked at the before and after, not just the after. So association studies are a problem.
Have you seen, yeah, that'll probably be pretty debated. Have you seen people with bad effects from fluoroquinolones that you suspect, or yeah?
Yeah. I mean, clinically, we've seen that. And I used to think fluoro's caused it until we started to, like I said, look at it a bit more and ask the question. But yeah, I've seen people that have had a flare when they've been put on the fluoro, but then have they had a flare because they've had a systemic illness, an infection that's created inflammation? If you've got the flu or a cold bug and you've got pre-existing knee pain, your knee will hurt you more. That's what happens. So if you've got pre-existing tendon issues and you're then ill, is that just what you feel and actually get with it? There is a large debate about a neural aspect of this as well. So there's a sort of, again, data that's mostly association studies suggesting widespread musculoskeletal problems with fluoroquinolones due to toxicity levels. And it may be that some people don't process the drug. It may be it increases your risk of neural stuff and other aspects. And that's something we need to be really cognizant about. So we are only looking at sort of the tendon rupture bit. We have done the tendinopathy test as well in this same data set. Doesn't increase your risk of tendinopathy. But again, we haven't presented or published that work yet. That will be coming as well. But it doesn't seem to carry a risk for either. It is ultimately where this is going. But I see plenty of patients. And if you talk to Matt Kenyon about it, he was in here earlier. He works up in Lancashire, so northwest of the UK. Matt will have patients regularly with this in the hospital as well. And this will allow us to reassure those people that this might be coincidental. It might not have been their drug. The fact you were given it doesn't mean you can't get better, and we won't be able to sort of settle you. This gets better at the same sort of rate and the same expectation of normal. And again, that's typically what we've been seeing a little bit in our clinical work.
Okay, yeah, the people I've dealt with, I don't know too much about it, so I'm just like, I mean, we're just gonna do what's common sense, and hopefully you're not just screwed and gonna have pain for much longer than someone who didn't have it. But yeah, I guess that's reassuring for them to hear if that's the case.
Yeah, sure.
Okay, last question I got for you, because I be conscious of your time here. When we come, I guess the tendon ruptures, tendinopathies, what's getting pretty big recently is this whole metabolic health thing, because I think in the past it used to be all load related, and the load is causing the issues, and then load is the thing that heals you whenever. Yeah, where do you stand with these metabolic problems? Do you think this is more so? Like I've thought older populations unhealthy, obviously metabolic issues, but I'm wondering if there's any thing carrying over to like the athletic population when it comes to this
Yeah.
affecting tendon structure.
So the metabolic thing's something we're working on, and the chap I've just mentioned, Matt Kenyon, has actually pioneered some of that work with us. So what we did with Matt, so just to give a bit of background, we looked at the National Health Service population. So we looked at patient notes from his hospital, 573 of them. We pulled them all and looked at their sort of patient history, their metabolic issues and other comorbidities. And basically what we found is that in their cohort or tendinopathic group, heart conditions, cancers, diabetes, respiratory disorders, all massively overrepresented compared to both a national average or a local average in that region. So it definitely is a problem. And the biggest issue for us is all the research is done on healthy people. These comorbidities are normally excluded in all of the existing publications, and that makes it really hard. So what we don't know is, does normal rehab work and do all these other things work? They do in our clinical work. And how I try and sort of then think about this is, and I often use it again on the sort of slides, use a wear and repair imbalance, which is what all of the tendon models talk about that exist in the world. It's basically stress on the tissue and then your recovery afterwards that influence whether you develop pathology. And it's just the metabolic conditions influence your recovery. So that's your ability to repair afterwards. If you're diabetic or if you've got high adiposity and that creates this systemic inflammation, that influences your general background inflammation and your healing rates because your immune system's busy. So that's really the key here, is that this may slow down recovery, but equally that the tendon cells are often so switched off because the person does so little exercise and activity to prime them that actually they might be easier to prime. And they might need to do so much less than an athletic person needs to do to lift that muscle strength and the metabolic activity in the tendon upwards, that actually it might be quicker as well. So we've got to consider it from both sides, but I'd look at the metabolic ones as critical. The mechanism is the same, but their background capacity is lower than the athletic person. So what their tendon can cope with, the activity levels is less for them. And that's really probably what we're talking about. And we will, of course, see metabolic conditions in our athletic group. So we might see type 1 diabetes, we might see junior or sort of juvenile arthritic complaints. So rheumatoid arthritis that's new onset. We might see things like psoriasis that then leads to psoriatic arthropathy, which commonly impacts the tendon before the arthritic issues develop. So we will see it, and it's underdiagnosed. One great example of this was an ex-athlete who had ongoing tendon problems and had surgery and all sorts of stuff, and then ended up with persistent pain 3, 4, 5 years later and wanted to chop his leg off because it was that bad. It was gout. When we got the blood test done, he had gout. It had been missed previously, put him on allopurinol to alter his urate levels, and symptomatically wonderfully better. So there's stuff like that where we need to think about metabolic stuff, particularly in non-responders or atypical responders. So yeah, definitely worthwhile considering athletes. In elite sports, they can get bloods done very simply. So often it's not missed. It's in our general group where we might miss it with our recreational runners from the local region and things. So
yeah. Yeah, I remember you had a lecture on, it's on YouTube, where you had that collagen degradation and synthesis graph, and then you added another line to show someone with the poor repair.
Yeah. So there's maybe genetic elements that influence that recovery. There may be dietary elements around protein ingestion that influence that. And we're learning more about the protein now. But again, I don't think collagen's anything special. And based on the study that's presented at Denmark recently at Sports Congress, in elite athletes, adding collagen on wasn't actually beneficial to their rehab for tendon complaints. It's probably just about hitting protein and hitting the recommended amounts. And then if they're not, then adding stuff on is probably better. But yeah, some people will get these weirder, longer recoveries for a whole variety of reasons. So yeah.
All right. I could just keep asking you questions, but we'll close it out. So
happy to come back and finish up.
Yeah, for sure.
I think no worries for that.
I think that'd be great. So yeah, you're the next thing you're doing, because I'm gonna, in April, you're coming to Traverse City, Michigan, so that Tendon Summit. But anyways, tell people outside of that, tell people where to find you online, if they can get in contact. You said your emails are flooded though, so but,
yeah. Drop me an email is always probably the best thing for people to find, rather than sharing my mobile number. Drop me an email, and if I don't respond in a few days, just chase me up. Some days, if I'm like in the lab or in meetings all day, I'll just miss messages, and then I've suddenly got 400 or 500 the next day to look at, and I can't physically get through that and do my normal work as well. So just chase me up if there's sort of something important and follow up. email's the best thing. Don't really run a website or do anything anymore like that. Still on Twitter or X, but use it less and less nowadays, with Elon being slightly interesting. So I think, like a lot of academics and researchers around the world, they've sort of dropped off it a little bit, but I still put out a bit on there. So that's the other opportunity as well, I guess, to reach out. And as you said, I'll be over in the States in April. Probably going to do a bit of an extended trip, go obviously to Traverse City, and then probably do a couple of trips to some NBA sides whilst I'm over as well. And yeah, a whole load of other conferences. I'm normally, unfortunately, on the conference scene quite regularly. So yeah, trips to rest of Europe and the UK over the year. Yeah, just get in touch if you want anything or want to ask a question, and I'll try my best to respond.
Perfect. All right, man. Thank you for coming on.
Thanks, Jake. Appreciate it, mate.